And welcome to this parallel session number 4 on hospital operation track. And this will be in 2 parts. The first part is for continuing quality initiatives. And the other one is hospital systems and improvement and operation efficiency. So for the part 1, it is the quality improvement initiatives. For this forum itself, there was a call for abstract and there was 212 submissions because of the call. But don't worry, we are just going to present three papers for the first part of our parallel session, which is quality improvement initiatives. And we have 3 papers to be presented. The first one is going to be presented by Ms. Madeliene J. Arevalo, Nurse 2, National Kidney and Transplant Institute. The paper is reducing the incidence of self-extubation in the intensive care unit. The second paper is to be presented by Dr. Carlene A. Cunana, Medical Officer 4 of Vicente Sotto Memorial Medical Center. The paper is Living with Congenital Heart Disease, Patient's Perspective. And the third paper or the presenter will be Maria Noel H. Robrigado, head nurse of Manila Doctors Hospital. The paper is Episode of Care, Categorical Approach in the Delivery of Efficient and Effective Bedside Care to COVID-19 Patients. Each of the presenter will be given 15 minutes for their presentation. The questions and answers will be conducted after all the presentations are done. The audience is on mute in the entire session. So if you want to pose a question, please go to the chat box or chat panel of this virtual session. And you can see the button that will open the chat panel at the bottom of this screen. Please identify the presenter you wish to address the question to and then state your question. The QA will only be 10 minutes. So we will only choose at least 1 question per presenter. So let us now go to the first presenter, which is Ms. Madeliene J. Arevalo, Nurse 2, National Kidney and Transplant Institute. The title of the paper is Reducing the Incidence of Self-Extubation in the Intensive Care Unit.
A pleasant afternoon to all our prestigious panel of judges, guests, and co-presenters. I am Madeliene Arevalo, staff nurse from National Kidney and Transplant Institute, here to present a continuous quality improvement study presented by the Intensive Care Unit CQI team entitled Who Got No More? Reducing the Incidence of Self-Extubation in the Intensive Care Unit. Lydia E. Hall's Core Care Cure model of nursing emphasizes the role of nurse in providing bodily care for the patient, performing tasks of nurturing, helping the patient to complete daily biological functions, and goal of comfort. With the main goal of providing maximum comfort and act as patient's advocate, we look forward to the improvement of patients' quality of life for those critically ill and most especially for patients that are admitted in the intensive care unit. This continuous quality improvement was initiated as independent nursing action to eradicate the incidence of self-extubation or unexpected pulling of endotracheal tube through patient's initiation. Patients that were being intubated experienced psychological, physical, and emotional stress. Through the use of this study, traumatic experiences on the patient's part will be minimized and comfort will be promoted. In line with our continuous effort in evidence-based practice that focuses on the process improvement towards providing quality outcome, reduction of patient-related incidents, and with the implementation of E3N program, and reinforcing a standard of practice in each area of care, is basically 2 steps forward towards the institution's objective, which is the patient safety. Since majority of patients being taken care of in the intensive care unit are already intubated or during their stay needs to be intubated, the role of nurse to provide maximum comfort and improvement of patients' quality of life, hence the initiation of this study that aims to lessen the incidence of self-extubation or the unexpected pulling of tube initiated by the patient. Establishing a more comfortable and patient-centered treatment plan designed specifically on each patient's unique needs is vital. In this study, factors will be identified and solutions will be provided to somehow preserve the patient's comfort for the reason of unexpected pulling of tube through patient's initiation. On problem identification and prioritization, we have identified 3 significant problems. 31.78% are from increasing incidence of self-extubation in patients in the ICU. From July to December 2018, 16 out of 51 intubated patients have had self-extubated, while 4.38% are from increasing incidence of moisture-associated skin dermatitis on critically ill patients. And lastly, 4.59% are from decreased compliance of visitors to scheduled visiting hours. Hence, the group decided that the number 1 problem should be prioritized. In the statement of the problem, from the data collected from the month of July to December 2018, 16 or 31% of the 51 intubated patients admitted in intensive care unit have had self-extubated. This is the Ishikawa diagram that illustrates all the probable causes related to the incidence of self-extubation of patients in the intensive care unit. From the probable cause under material, the first problem identified is the limited option of cloth tape in the central supply and sterilization unit. And due to the low quality of the adhesive material being used, it results in ineffective anchoring of the endotracheal tube. The second probable cause under method is the no standard policy in sedating patients during intubation. Patients that are due for intubation are usually conscious, while intubation process is painful and uncomfortable, patient becomes agitated or distressed. The third probable cause under material is the limited stock of endotracheal tube holder available at central supply and sterilization unit. The fourth probable cause under man is the no standardized policy in applying and using restraints due to lack of training for the proper use and application of restraints. And lastly, the fifth probable cause would be the lack of training on proper application of endotracheal tube holder, and because of that, staff nurses has limited knowledge on the proper utilization and application of endotracheal tube holder. Final objective statement. Our final objective statement is to reduce the number of cases of self-extubation of patients in the intensive care unit of National Kidney and Transplant Institute from 31% to 10% by the end of October 2019. For the solution implementation, the plan is to coordinate with the central supply and sterilization unit in availing endotracheal tube holders. What we have done is we have instructed intensive care unit nurses to utilize endotracheal tube holders for securing patients' endotracheal tube if it is not contraindicated. Then we check through regular monitoring of supplies and availability of endotracheal tube holder in the central supply and sterilization unit. And lastly, we act through continuously monitoring of the compliance and a proper sanction was given for non-compliant staff in the utilization of the material. On our solution implementation, last August 19, 2019, we have conducted demos on proper application of endotracheal tube holder. And we have been continuously monitoring in doing proper endotracheal tube holder application with the ICU staff through conducting in-service education through the monthly unit meeting. We also created guidelines in applying restraints, and we have conducted seminars and trainings on the standardized guidelines on applying and caring for patients with restraints. We have also provided monitoring tool to assess and evaluate patient safety while on restraints. Restraints are applied after consent was been secured, and usually it was removed once patient does not have the risk of pulling the tube. On the evaluation of results, the chart shows that 31% of the patient that has self-extubated in the intensive care unit from July to December 2018 has significantly decreased to 8% from June to August 2019 after the solution implementation. The final figure is 2% lower from the original target goal of 10%. The team created a guideline in proper application and care of patients on restraints and implemented the use of endotracheal tube holder instead of the traditional adhesive tape. Using the guideline and a new way of securing endotracheal tube, we have only tallied 3 out of 36 intubated patients who facilitated self-extubation, which suggests 74% decrease in the incidence of self-extubation from our previous tally. We have achieved the desired reduction in percentage of incidence of self-extubation from June to August 2019, from 31% down to 8%, which is below our target 10%. One of the significant impacts of this study is seen in the financial aspect on patients' hospital bill. The table depicts the estimated expenses of patients who undergone self-extubation. This may vary on case-to-case basis, but we took it in consideration that multiple reintubation may result in infection, thus prolonging the hospitalization. Through this project and proper implementation of the solutions, we will be able to save patients from enduring physical, emotional, and financial stress and save them from the agony of prolonging their stay in the hospital. This table reflects the estimated expenses of patients who self-extubated that will have probably reached around 71,000 pesos. However, using an endotracheal tube holder would only cost around 1,800 pesos. The radar chart depicts the improvement in the productivity and the quality of healthcare delivery by having a competent nursing staff, by helping and upholding patient safety, and making them decide easily to come back to our institution due to satisfaction, thus making our institution profit from it. This table depicts the latest tally of self-extubation in the intensive care unit from January to June 2021 with only 2 out of 140 intubated patients. And with that, we humbly honored to present the continuous quality improvement of the intensive care unit in National Kidney and Transplant Institute. A pleasant afternoon to all. Thank you.
Thank you very much, Ma'am Chavez. Miss Arevalo, rather. Then the second paper is Living with Congenital Heart Disease, Patient's Perspective. The presenter is Dr. Carlene A. Cunanan, Medical Officer 4 of Vicente Sotto Memorial Medical Center.
Good afternoon. I'm proud to present our paper entitled Living with Congenital Heart Disease, Patient's Perspective. I am Dr. Carlene Cunanan, Medical Officer 4 of Vicente Sotto Memorial Medical Center. Congenital heart diseases are the most common congenital defect with an incidence of 8 to 12 per 1,000 live births worldwide. The past century has seen many advances in the correction of these CHDs as babies and young children, leading to an increase in the population of adults with CHD. The clinical outcomes of these interventions have been well documented. However, the psychosocial impact of living with CHD has not been well explored because of minimal research on the psychosocial effects of CHD among children. A local study looking at how children with CHD perceive their disease and how it impacts their thoughts, feelings, and behaviors has yet to be published. This work has allowed us to hear what children with CHD have to say. Based on the review of related literature, shown here are the interacting constructs under the domains of self and condition, family and peers, and perception of the future of children with CHD, which this study aims to identify. There has been conflicting data on the effect of the cardiac diagnosis on the patient's psychosocial outcomes, with some studies citing poor outcomes, while others finding positive and even better psychosocial outcomes compared to the general population. The ultimate effect of all these variables will be on the patient's quality of life, an important goal of treatment in chronic illness. The purpose of this study is to describe and report the health-related experiences of children with CHD in VSMNC in order to identify their needs as a basis for improvement of care. The specific objective is to describe the living experience of the child in relation to his or her CHD as to the following: self and condition, family and peers, and perception of his or her future. This was a qualitative study using semi-structured in-depth interviews on school-aged children 8 to 17 years old diagnosed with CHD enrolled in the VSMC Cardiac Congenital Clinic. This was conducted at the interview room at the WCPU. Guide questions for the 3 domains were used. Audio recording was taken with consent. Framework approach was used to analyze the data. 11 patients were initially contacted. 1 patient refused while being oriented with the consent and assent forms. Thus, a total of 10 children were included in the final study. 3 of them had cyanotic heart disease, while 7 had acyanotic heart disease. 5 of them had already been operated on. This table summarizes the themes that emerged from the domains of self and condition, family and peers, and perception of the future, which I will now tackle one by one. Physical limitation of activities was an expected finding in children with CHD. This study found that these children can be physically active, but were restricted by their parents because of their lack of understanding of their children's disease, causing unwarranted limiting of life opportunities and social participation for the respondents. Indeed, Chuck et al. Found parents had significant knowledge gaps that needed a refining of their parent education program. Moreover, physical symptoms may cause physical and motor inhibition constraints that directly affect their emotional and cognitive development, as well as neurodevelopmental problems, which include mild deficits in cognition, attention, and neuromotor functions. Respondents also described their physical symptoms as being precipitated by or worsened by highly emotional states. It is inconclusive if these are signs of anxiety or a direct effect of the cardiac condition itself. A cross-sectional study on mental health disorders in children with CHD found that youth with CHD of all severities had higher odds of these mental health and behavioral issues compared to those without CHD. Self-esteem is a central issue for the respondents who are teenagers. Several studies have shown low self-esteem in patients with CHD. Jahangiri found these factors that were significantly associated with low self-esteem among these children. This is consistent with the findings in this study. Some respondents verbalized having low self-esteem and not knowing how to take care of themselves. Most of the respondents had interruptions in their education due to their cardiac condition, limiting their social interaction, which can negatively impact intellectual performance and also contributes to their feelings of isolation. But despite these experiences, and regardless of severity of disease, the respondents generally declared that they were happy. So this is a self-drawing of one of our respondents in the study. This points to resilience. Indeed, the respondents shared positive learnings through their experiences, especially those who had already undergone surgery. Spiritual inspiration has been found to be a protective factor in the development of resilience. All of the respondents cited having faith in God and being with family as their primary source of happiness. But one of the respondents in this study did not resonate with the others. She had a sense of entitlement, as she believed that she should receive preferential treatment due to her heart condition. This is considered to be a coping mechanism. Another coping mechanism is denial. Some of the respondents denied the actual symptoms that were present, while others had difficulty in accepting their condition. Shearer et al. Found that CHD patients saw themselves as normal because they had a satisfied sense of self, meaning they accepted themselves for whom they were. In contrast to this study, some respondents felt that they were normal, but it was because there was a lack of understanding of their cardiac condition and how it affected their bodies and physical functioning. Leventhal's illness perceptions model can be helpful in the formulation of a module to improve illness representations in children and their families to prevent the development of psychopathology, as it is found that CHD children are 2 times more likely to develop psychopathology than healthy children, irrespective of the type of cardiac defect. Bullying is another challenge shared by some of the respondents that put their coping strategies to the test. Whether they experienced being bullied at some point or not, all of the respondents in the study expressed in some way their desire for belongingness. They also felt misunderstood by peers. But when asked what their sources of happiness and support were, all the respondents answered family and school. So here are actual drawings of the respondents of their family and school. On the downside, they thought that they were being overprotected by their family and teachers. Excessive parental protection contributes to psychological distress, poor psychosocial functioning, and health-related quality of life in children with chronic disease, which may persist to adulthood. One adolescent respondent did say that she does not know how to take care of herself, as shown in the previous slide. Like their parents, teachers also contributed to the respondents' functioning by restricting their activities and providing special treatment, like not marking the respondent absent when the latter missed class due to medical issues, and even providing a special student assistant. This leads to the concept of miscarried helping, wherein well-intentioned protective behavior leads to unsupportive relationships that become detrimental to the child's development. As this study shows, practically all emerging teens under the domain of self and condition were influenced by the social domain of family and peers. Despite the young age of the respondents in this study, most of them have shown many forms of positive thinking and optimism. Despite a few of the respondents admitting uncertainty of the future, they had dreams of becoming policemen, teachers, doctors, and engineers. This positivity is consistent with the hypothesis of sense of coherence, which tries to explain why patients who grow with chronic diseases, such as CHD, may be satisfied with their lives. As Bertoletti put it, children with CHD are challenged to develop a sense of coherence earlier than their peers, as they are subject to situations that require a great capacity for adaptability. Pediatric patients with CHD go through different challenges, not just physically, medically, and financially, but socially, mentally, and emotionally as well, which all impact their outcomes. Consistent with other studies, psychosocial support is necessary in the development of a general sense of well-being in these children. The themes that emerged under the category of self and condition were all influenced by social factors under the category of family and peers. Despite the negative themes of overprotection, feelings of isolation, and bullying, the respondents showed resilience, including optimism of the future, albeit its uncertainty. Restriction of activities, denial, and overprotection all stemmed from the respondents and their caregivers' inadequate understanding of their cardiac condition. Indirectly, this study shed light on how the respondents and their caregivers actually perceived their disease. The respondents developed their own coping strategies, both beneficial and detrimental, to be able to deal with the challenges they face. Healthcare providers must first understand and appreciate how the patients and their caregivers perceive their disease and recognize that this may impact them differently. Holistic approach with a team of helping professionals composed not only of doctors, but also mental health professionals, child psychologists, social workers, occupational therapists, is thus imperative. This study recommends the following programs: resilience programs, programs for developing coping strategies, peer support interventions, program against bullying. The following should be incorporated in the routine clinic follow-up of all patients with CHD. Neuropsychiatric clinic to screen for behavioral and mental health issues, the use of an OP or parental overprotection scoring tool to recognize and intervene in instances of parental overprotection, foster self-reliance, and positive psychosocial adjustment. The use of Leventhal's illness perceptions model to correct any misrepresentation of the patient and their families to reduce their perceptions of the emotional impact of their cardiac condition. Continuity of the formal education of the patient should be a major consideration in the holistic management of the patient, such as collaborating with children's schools so that they can continue learning their lessons even while inside the hospital. To better capture the complexity of CHD patients' experience with their disease, research pertaining to patients' health, quality of life, or functional status associated with illness or treatment is important. Thus, the following research studies are recommended. The goal being a creation of a standardized program for pediatric patients with chronic disease. Thank you. These are my references.
Thank you very much, Dr. Carlene A. Conana. Thank you all. So our last presenter for this part one is Maria Noel H. Roblegado, head nurse of the Manila Doctors Hospital. The paper is Episode of Care, a categorical approach in the delivery of efficient and effective bedside care to COVID-19 patients.
Good afternoon, everyone. In line with our vision to provide quality and safe nursing services to our respected clients, we are here to present the COVID-19 bedside care action research we have formulated in the midst of the pandemic last 2020. Our program is entitled Episode of Care, a Categorical Approach in the Efficient and Effective Delivery of Bedside Nursing Care to COVID-19 Patients. I am Maria Noel Robregado, and I am here in behalf of our co-investigators, Joseph Villagracia, Judeline Delgado, Selma Taligatos, Maria Magdalena Consad, Arvin Hoson, and our advisor, Dr. Rodolfo Borromeo. Let me explain the background of our project. The number of people infected with severe acute respiratory syndrome coronavirus 2 is dramatically increasing worldwide. On January 30, 2020, the World Health Organization declared the COVID-19 outbreak a public health emergency of international concern. In the Philippines, enhanced community quarantine was mandated to prevent the transmission of the virus and other preventive measures. In Manila Doctors Hospital, the team designed a procedural algorithm focused on the immediate treatment and management of these patients. Suspected cases were then brought to the COVID units for proper containment measures and addressed the need. In response, the Nursing Service Directorate formulated a systematic approach to deliver effective and efficient bedside care by categorizing the activities dependent upon the levels of care and requirement of each patient. At the onset of the pandemic, focus were driven through the treatment of symptoms presented by the patient without any modality of nursing care. With this in mind, the team convened and advanced several approaches on how to properly deliver patient care at its convenience. Upon brainstorming, the group agreed to lay out specifics according to COVID category as to mild, moderate, severe, and critical cases, so that the nursing staff will be guided suitably, maximizing the resources, time, and effort in the provision of utmost care needed by our patients. These activities were then assessed and subcategorized considering its significance and prioritization of nursing care. Basically, our study is focused on the non-establishment of bedside care category for COVID patients for more than a month from the start of the pandemic. The team would like to ensure the effective and efficient delivery of nursing care to COVID patients throughout the admission process. We gathered the possible causes of the problems and formulated a simplified design focused on the independent nursing care to cater the needs of the patients as well as the dependent ones. Categories includes patients' activities of daily living, monitoring processes, use of machines or equipments, diagnostics, therapeutics, and as well as the psychological status and well-being of our patients. The investigators would like to determine the direct relationship of our staff in performing the COVID-19 bedside care. In achieving the outcomes of this study, we face various challenges in the performance of the bedside care as to the perceived threats and other experiences during the COVID-19 pandemic. With the above conceptual framework, the investigators would like to answer the following objectives. Enhance the skills of nurses in the delivery of bedside nursing care through its mastery, having a dedicated guided care per case category. Establish a protocol on the delivery of bedside care by categorizing it to mild, moderate, severe, and critical cases. Ensure quality of service and patient safety in the COVID units by increasing the coping mechanisms of staff nurses in the delivery of care among COVID-confirmed patients, and to increase the recovery rate and decrease the mortality rate among COVID-confirmed patients by excellent provision of the bedside care protocols. The following methodologies were utilized to achieve the aims of our study. This includes knowledge assessment survey, root cause analysis, an observational checklist post-implementation phase of the device modality of care, creation of bedside care per case category of COVID-19 as to mild, moderate, severe, and critical, formulation of the common clinical manifestations and its corresponding interventions, monitoring of nursing skills mastery in the delivery of care to COVID-19 patients, creation of a monitoring checklist for the mental health status of the staff involved in the delivery of bedside nursing care, and standardization of the device bedside care and educational nurturing among the staff assigned at the COVID units. The following measurements were utilized to help us even get better with our outcomes. We also utilized the Deming cycle to outline our logical investigation to continually improve our study. And with the above-mentioned methods and strategies, I am proud to present to you the following results. At the start of pandemic, nursing skills is at the competent level. But as time goes by, and with the established COVID-19 management, mastery of nursing skills went up to expert level. This is done through the utilization of a checklist and observation of practices while doing the actual bedside care services. Psychological well-being of staff is monitored and given utmost attention and priority in order for them to be in their best state of mind while caring for our patients. The study showed that nurses will continue to provide quality and efficient care and do the right thing even in the face of fear, anxiety, and other concerns about safety. Staff felt that Manila Doctors Hospital is a safe and conducive hospital to work in during this pandemic. The baseline data shows a 39.5% recovery rate and a 30% mortality rate during the first weeks of March 2020. With this study, there has been a 26.19% decrease in the mortality rate from March 2020 and a 36.25% increase in the recovery rate at the end of December 2020. Presenting to you the sample of the device bedside care, which is the main element in this study. To carry out the task and significantly improve patient care outcomes, the Nursing Service Office redesigned staffing complement that caters to the current needs of the COVID-19 patients. They reshuffled more seasoned nurses and nursing auxiliaries that will handle these cases and more adept to the recent situation. Some inpatient non-COVID units were closed and deployed staff to COVID units to augment the manpower complement after adequate training. Other tangible and intangible benefits includes a 75% reduction in the medication errors because of the systematic approach in the provision of bedside care to COVID patients. Nurses carry out the task positively by accurate administration of medications because they are already familiar with the COVID setup and treatment regimens. With the tender loving care and quality and safe services provided by the staff, equates the positive customer experiences, leading to their fast recovery, thus these expressions of customer delights. With the above results, the team came up with the following conclusions. The device bedside care per COVID-19 category significantly improved the nursing care outcomes by the expert delivery of care by our seasoned and new nurses in the COVID units. Despite the negative attributes brought about by this pandemic, frontliners still believe that Manila Doctors Hospital is a safe and conducive hospital to work in. Nursing skills mastery increases from 3, which is competent to perform the bedside care, to 4 as experts in the field and able to assist others in the delivery of desired nursing care to patients. And with teamwork, we can increase the recovery rate despite that there is no specific treatment regimen for COVID, and decrease the mortality rate of COVID-19 patients with a systematic approach in the delivery of bedside care. To ensure sustainability in this safety initiative, a team development plan was devised and involved the following activities: continuous implementation of the device bedside care plan category, and re-strategize after evaluating weak points and after deployment of new treatment regimens. Constant communication and collaboration with infectious disease specialists and other attending doctors for better patient care outcomes. And lastly, converted the device bedside care plan category into a training module to be part of the training program of newly hired nurses. For our future plans, the team would like to implement the following recommendations: collaborate with the infectious disease specialist and internal medicine department in the creation of a clinical pathway for the admission of COVID-19 patients, and to perform weekly safety huddles to proactively create strategies in the improvement of the bedside care. This ends my presentation. We fervently hope and pray that this pandemic will end too soon. Thank you very much for your kind attention.
Maraming salamat po kay Maria Noel H. Robrigado for your presentation. Now let's go to the questions and answer. I'll turn you over to Architect Paolo.
Hello po. For questions po, you may post your questions sa chat po. As of now, wala pa po atang nagtatanong. So,
yung may isang issue dyan, yung copy daw ng presentation.
yes po, for the copy of the presentation po, first we will ask po the permission of each researcher po and presenters if it can be shared po. It can be shared po. Thank you po.
Wala akong magpo-question. Sayang naman, ang ganda po ng mga presentation.
For the attendees po, please chat your questions po if ever meron po tayo.
You have 77 attendees.
Ayun po, meron po from TPDH-CQI po. We just want to ask how they were able to persuade your staff nurses to lead projects in their respective hospital. May I ask po kung kanina po address itong question po na ito?
KTI at Manila Doctors. Nurses sila.
Or ano daw po, NKTI and Manila Doctors po.
Ma'am Arevalo or Ma'am Robigado, would you like to answer the question? Would you like to
Hi, ma'am. Good afternoon.
Good afternoon. The question was?
Yes, ma'am.
Question was, want to ask how you were able to persuade your staff nurses to lead projects projects in their respective hospitals po?
Actually, sir, it's a part of our annual or yearly continuous quality improvement. So as staff of intensive care unit, we sometimes initiate projects like this, the creation of CQI pertaining to more specific and more specific problems or the more obvious problems that we encountered on our everyday duties. So as part of our initiative and to make our work and make our goals for the patient safety, we staff nurses do this annual CQI or continuous quality improvement.
Okay, that satisfies your question. Si Ma'am Robrigado, do you want also to answer the question?
Hello, ma'am. Good afternoon.
Good afternoon.
Yes, ma'am. Ma'am, in Manila doctors po, we are the same with the NKTI that we also have an annual performance of the we
Okay.
usually also get in the recent from encounter. But in our partners are facing now the COVID-19 virus. That's why we keep up this project also. Parang bago kasi siya we are still on the process of learning the new treatment management for this disease po.
May follow-up question po. Do you have prizes for the CQI initiatives? Ito po, is this rewards po ba for the initiatives
Of the hospital.
of the hospitals? Pertaining po sa question po. Thank you.
Directed towards the three speakers.
Hello, sir. Hello, ma'am. And this is Noel po again from doctors.
Yes,
Yes, ma'am. For our CQI initiatives, we have prizes for the hospital provide us with the prizes and awards po for this projects po.
So, ayun po. Thank you na satisfy naman po ata yung answer po natin sa question po. So, to provide the session synthesis, I'll turn you over to Ma'am Gabby po. Thank you po.
Okay. Let's go to the synthesis of the session on the continuing quality improvement initiatives. So once again, I would like to thank our presenters for their work and advocacy on quality improvement focused on patient care. Ms. Madeliene J. Arevalo of NKTI presented their hospital's effort to improve nursing care by reducing the incidence of self-extubation in the patients in their ICU from 31% to 10%. She showed us that they were able to reduce the incidence to 1%. She incorporated CQI tools in studying the situation and in coming up with the solution to the given problem. Dr. Carlene A. Punanan presented a paper that showed one of the elements of quality, and that is people-centered care, particularly on the patient's experience. She discussed on how the children understand their illness, their outlook for the future, their uncertainty of the future, and their desire for social contribution. She discussed the need for psychosocial support and other interventions were recommended. Ms. Noel H. Robrigado gave the private hospital a representation in this forum. Her presentation was on the episode of care, a categorical approach in the delivery of efficient and effective bedside care to COVID-19 patients. Her presentation showed that the nursing skills mastery increased to level 4, experts in the field as well as an increasing coping mechanism of health workers. Likewise, she discussed that the need for teamwork to increase the recovery rate of COVID-19 confirmed patients. We are truly grateful that these advocates for continuing quality improvement were able to present this paper for the purpose of all our learnings. I hope their these advocates will increase in numbers so that it will truly address the need for improvement of our healthcare services. So with that, let's move on to the part 2. Oh, magbe-break daw po tayo ng 10 minutes for the part 2 of our parallel session, hospital operation track. At ang part 2 natin is hospital systems improvement and operation efficiency. So in 10 minutes, we will be back. Thank you po.